Tuesday, September 22nd, and we're going to be talking about influenza. As we approach the 2020-21 influenza season, today my goal is to give you some updates. This talk is not intended for specific medical advice, but for general education. I have no financial interest or ownership in any company or product that I'm going to be talking about today. I will mention a couple of tests by name, and that's simply because that's what we're using here, and my goal is to make you familiar with what we're using. So the objectives today are those paying attention should be able to discuss and demonstrate diagnosis of influenza-like illness, choose appropriate options for treatment for patients with influenza-like illness, and appropriately counsel patients regarding prophylaxis, vaccination, and isolation. So this is kind of the schematic of what we're going to follow today, starting with epidemiology. We're going to then move into diagnosis, treatment, and we're going to end with prevention, because I want to end on what's most important for us. This slide shows the tracking of the previous influenza season from 19 to 2020. And the graph shows the percentage of medical visits for influenza-like illness over time. So the x-axis on the bottom shows numbers that start at 40 and go up to 52, and those correspond to the weeks of the year. So number one there would be the week ending January 1st of 2020. You can see that the flu illness had a very unusual pattern this past flu season with 3 separate distinct peaks. And that is pretty uncharacteristic. It was a large a large burden of influenza illness. And the next graph I'm going to show you overlays that on top of multiple other influenza seasons. So you can kind of see how that compares. You'll note that one highly unusual year was the 2009-2010 flu season. That was when we saw an outbreak of a novel H1N1 virus that was attributed to swine, and that actually peaked in the early part of the fall. However, generally speaking, you can see that the peak timing of influenza seasons tend to overlap. Some seasons are worse than others, and as we mentioned, the last flu season, 19 to 20, was one of the more significant burden of influenza that we've seen in recent years. The next graph highlights different types of flu specimens. So this kind of tracks the flu testing that comes into the state laboratories. Does it ultimately test positive for flu A, flu B, and it actually breaks down the different lineages. I'm not going to spend much time on this, other than to say that last flu season, we saw a higher proportion of influenza B cases over the course of the flu season. And yeah, every year is a little bit different pattern. So influenza is a pretty major illness, and it causes significant morbidity and mortality. In children, the most common complication is actually otitis media. We see a lot of otitis media, and we don't always think flu, but during flu season, you want to consider that as a potential cause. Obviously, lower respiratory involvement is the most the thing that we often think about first. That can include clinical syndromes such as pneumonia, bronchitis, bronchiolitis in young children, and croup, which actually causes a more severe case than the typical seen with parainfluenza, and of course can cause exacerbations of asthma. Other known complications include primary influenza pneumonia, which is inflammation within the lung tissue. This is a severe complication, fortunately less common among influenza cases. This is caused by the influenza virus directly invading the lung, and it tends to present with tachypnea, shortness of breath, and can present with cyanosis. Patients with influenza can also end up with secondary bacterial pneumonias. These actually contribute to about 25% of all flu deaths, and the most common offenders are strep pneumococcus and Staph aureus. There's a typical pattern wherein the patient starts to recover from their influenza illness and then has a secondary sickening with a much more severe course. This graph shows some very sobering statistics that every single year in this country, a number of children die as a result of influenza and its complications. And as you can see, the last year was no exception, and it was one of the highest number of pediatric deaths, reaching a total of 188 pediatric deaths. So we care a lot about influenza and certainly want to prevent and treat it aggressively. Some other uncommon complications, you may have not seen these before. I have not seen most of these, but flu can be associated with myositis and rhabdomyolysis. This is more frequent in children, and it's characterized by extreme muscle tenderness. Flu can have some CNS complications when it affects directly the CNS, causes a lot of inflammation there, and can lead to clinical syndromes of encephalitis, transverse myelitis, aseptic meningitis, and Guillain-Barré syndrome. Flu can also affect the heart muscle directly and can cause myocarditis and pericarditis. And lastly, when flu is associated with Staph aureus infection, we can see toxic shock syndrome. Numerous risk factors have been noted for severe complications of influenza, and many of these should be well known to you, but over the age of 50, under the age of 5, patients who are pregnant or within 2 weeks postpartum, certain race and ethnicity groups such as Native Americans or Inuit patients, residents of nursing homes, and then several medical conditions that can be associated with complications of flu. And most commonly, we see a lot of folks with pre-existing pulmonary disease, diabetes, and cardiac conditions. Of note, hypertension is not considered a risk factor for severe complication of flu, but other cardiac conditions such as congestive heart failure would be significant increased risk. We do see a growing number of Americans who are obese or overweight, and of note, severe obesity with a BMI over 40 is a risk factor for severe complications of influenza. So with transitioning now to diagnosis, flu is primarily a clinical diagnosis. Majority of patients can be diagnosed clinically during outbreaks in times of high flu activity. You want to consider diagnostic testing during times of low flu activity, particularly early in the season before we're really starting to see an influx of cases. This year with the COVID-19 pandemic, which is ongoing, will also complicate the attempts to diagnose flu clinically. Children in particular are more difficult to diagnose because their symptoms are often either not reliably reported or they may have somewhat different clinical presentation. The typical presentation of influenza consists of abrupt onset of constitutional and respiratory signs and symptoms. I've had influenza twice in my adult life, and I can vividly recall the onset of flu, waking up in the morning, feeling just a little bit off and not really wanting to eat, not really nausea per se, but just didn't really feel like eating. And I thought, you know, I'm going to wait a little bit before I eat. And then within an hour, having significant myalgias and kind of like the shaking chills and just immediately knowing something is definitely wrong. Very abrupt onset. The symptoms, most common symptoms are listed out here, and you'll note that there's an awful lot of crossover between these symptoms and COVID-19. While I'm sure I've had coronavirus infections, to my knowledge, I've not had COVID-19. My understanding and my limited experience with COVID-19, I feel that the onset tends to be a little bit more insidious. So again, among children, otitis media, nausea, and vomiting are predominant symptoms, oftentimes. And the other characteristics in children to be cognizant of are that infants less than 6 months of age are less likely to present with fever and cough. Their syndrome can be harder to diagnose, and they can often be sicker than they let on. Older children, meaning not infants, but still young, kind of school-age children may have very high fevers and may even appear to have bacterial sepsis. Among children who are sick enough to be hospitalized with influenza, we do see febrile seizures in a significant percentage of those children. About 4 to 11%, depending on the study, will go on to require ICU level care. And almost 3% will require mechanical ventilation due to the influenza virus. So we do have testing available for influenza. There are actually several different tests available. I have a table that I've included in this slide set that you'll be able to access once the slide set is posted, showing various features of different testing that are available. We'll talk quite a bit today about rapid influenza diagnostic testing. We won't talk too much about reverse transcriptase PCR, direct fluorescent antibody, and other tests because they're just less commonly employed. There is a possibility of viral culture, but that's pretty impractical as it takes 2 to 3 weeks to get results back. It is important to try to collect your specimens early in the course of illness, and this is in symptomatic folks, of course, but once they're over 4 days from the onset, some of the testing is going to be less sensitive. So I'd like to zoom in on rapid influenza diagnostic testing. And as you can see, I've included an image here of one particular test, which is the Sofia Influenza A/B rapid test made by a company called Quidel. And I've included a table, and I recognize the print is really small, but this lists the product specifications, and this is off of the Quidel website. And they list the sensitivity and specificity for the performance of their test. And I want to just point out for nasal swab sensitivity, they report 90% and a specificity of 89. And for nasopharyngeal swab, they report a sensitivity of 97% and a specificity of 90. So the specificity is about 90% in both cases. And in fact, over all of these different ways of collection, the specificity is about 90%. But the sensitivity will vary based on the method of collection. And what we tend to do here in our clinic and what our staff is trained to do is a nasopharyngeal swab, which means you're sticking that Q-tip all the way to the back. And some of you have gotten to experience that this year. So how does this particular test perform in the real world? This is a publication from Open Forum of Infectious Diseases back in 2017, so this is about 3 years old now. There was a small RCT performed in an extended care facility environment over the 16-17 season. This involved 228 unique patients. Basically, once they identified an acute respiratory illness in this nursing home, they collected a nasal swab specimen. It is important, based on the information I just gave you, I want to highlight that they use nasal swab as opposed to nasopharyngeal swab. They then performed rapid influenza diagnostic testing using this Quidel Sofia rapid test, and they sent these swab also for confirmatory influenza testing with a RT-PCR test. They additionally performed the Luminex respiratory pathogen panel, so looking for other respiratory pathogens. The overall sensitivity and performance for detection of influenza A and B was determined to be 79.2% with a specificity of 96.1%. While those numbers are a little bit less good than what is presented on the website, this is within the ballpark. And again, of note, these were nasal swab specimens, and we believe that the nasopharyngeal are a little bit higher sensitivity. Even with these numbers, these sensitivity numbers, mathematically estimating the likelihood of discovering one of the first 2 influenza cases within an extended care facility was estimated to be greater than 95.7%. So this is found to be a useful method of determining influenza, and particularly in the start of the flu season. Of note, by the RCT performing the respiratory pathogen panels, influenza was the most commonly detected virus, followed by, and that was a percentage of 14.5% was influenza B, 7.5% was influenza A. So collectively, influenza was a little around 22%. Followed by rhinovirus/enterovirus, which was 13.2%, RSV, which was 11%, and coronaviruses, which were 10%. So I thought that was interesting because we don't do a lot of respiratory panels here, but in this particular study, those were the common players. So this is actually a video. I don't plan to play this video. I feel like we've all become much more familiar with nasopharyngeal samples. And again, many of us have gotten to experience that this year in the setting of the COVID-19 pandemic. But you'll be able to go into slides, play this video, and it shows the collection of the nasopharyngeal sample. Shifting gears, I'm going to start to focus now on treatment of influenza. So we're really zooming in on patients who are symptomatic, who have an influenza-like illness with or without testing of influenza. So I want to highlight these categories of patients who should be seen as priority for receiving treatment of influenza-like illness. And those include hospitalized patients, really anyone hospitalized with influenza-like illness, unless contraindicated, should receive treatment for influenza. Anyone with progressive, severe, or complicated illness, which probably is the same bucket of folks that are already in the hospital. Anyone who's pregnant, and I want to highlight that even if it's more than 48 hours since onset of illness, that we want to treat our pregnant patients, generally speaking. Patients who are less than 2 years of age or greater than 65 years of age, because they're known to have increased complications for severe influenza. Anyone who's immunosuppressed or taking certain chronic condition or has certain chronic conditions, such as on the previous slide. And then residents of nursing homes and assisted living. So within those patients who are in the hospital, it is recommended to test them to try to confirm the diagnosis. However, it is important to make sure that you're treating them empirically, even if the rapid test is negative. In other words, don't hang your hat on a rapid flu test if the patient has influenza-like illness in a hospitalized setting. It's thought to be better to go ahead and treat empirically, and then to do some confirmatory testing, such as an RT-PCR for influenza. Definitely want to start infection prevention and control measures, and you want to do that immediately. Again, even in the setting of a negative rapid flu. This year, we're doing a lot of that, of course, in the COVID pandemic. Flu is droplet isolation, so that is just, typical surgical mask and gowns. There are 4 treatment options available for influenza. 3 of these medications fall in the class neuraminidase inhibitor, and those include Osultamovir, which is also known as Tamiflu, Zenamovir, which is also known as Relenza, and Paramavir, known as Rapivab. There is a new class of medications for treating influenza that was approved in 2018. There's only one drug in that class, and that is Baloxavir marboxil. I don't know who comes up with these names, but it's a little bit of a mouthful. The brand name is Xofluza. That's not much better. And so I'm going to go through these drugs one at a time and kind of highlight some of the key features. I definitely think you should be familiar with Osultamovir. I'm sure that you've probably prescribed it in the past. Osultamovir will treat both flu A and B. The typical adult dose is 75 milligrams twice a day for 5 days. And it comes in about $50 per course. And the dose pack comes with 10 capsules. It has some adverse effects, and those include nausea and vomiting in about 1 in 10, headache also about 1 in 10, and then rare reports of neuropsychiatric events. And that primarily was like depressed mood, psychosis, and self-harm. Those neuropsychiatric events primarily came out of studies from Japanese pediatric patients, and we don't have a very adequate handle on what the actual rate is, but it is thought to be rare. I want to make note that over 98% of currently circulating influenza virus in the US is Osultamivir susceptible. In other words, Osultamivir is an effective treatment with low resistance. You can use Osultamivir in really all ages. The dosing in young infants is kind of standard. Actually, the dosing in children and older infants is kind of standardized and is on a grid, which you can find in UpToDate and a lot of other resources. For very young infants, it's weight-based, and it's 3 milligrams per kilogram per dose. Again, if you're treating illness, that's twice daily for 5 days, just like the adult dosing regimen. The suspension of Osultamovir is 6 milligrams per ml. So for easy math, you can also try to remember that it's half of an ml per kilogram per dose. Oop, I'm sorry, I got a little slide happy there. You do need to adjust Osultamovir dosing for folks with chronic kidney disease. And this is a chart, again, widely available, but you can see that if the creatinine clearance is 31 to 60, so kind of in that stage 3, then you decrease the dose to 30 milligrams BID for treatment. And with lower creatinines, you adjust it accordingly. For folks on hemodialysis, you want to dose it after every hemodialysis. Switching gears, there's also Zenamovir, this is a little different because it's an inhaler. It'll also treat both flu A and B. It is not recommended for patients with pulmonary disorders such as asthma due to the risk of bronchospasm. The dose is 2 inhalations twice daily for 5 days, and it runs in about $80 per 5-day course, so it is more expensive. It has some adverse effects. For folks who are not ill but are using it for prophylaxis, it's been shown to cause sore throat, cough, and nasal symptoms. Anywhere from 1 in 5 to 1 in 10 people who use it. It can also cause urticaria, abdominal pain, dizziness, and arthralgias, all of which happen in about 2% of patients who use Zenamovir. Zenamovir is on the IU Health formulary, as well as Osultamovir. The third and final neuraminidase inhibitor is Paramavir. This one is unique in that it is only intravenous. It also treats both flu A and B, although there's limited data on the efficacy of Paramavir, and most of the data was in a trial that the predominant strains of influenza was type A, influenza A. In other words, there's very limited data that it is effective for influenza B, but it is assumed to be so due to the class effect. This is a one-time intravenous dose. It is approved for treatment of flu in ages of 2 and up, and it causes some adverse effects listed here, diarrhea as well as constipation, neutropenia, which is unique, and I didn't see that listed anywhere in Lexicomp as an adverse effect for either Zenamovir or Osultamovir. And it can cause serious skin reactions, including erythema multiforme and Stevens-Johnson syndrome. Paramavir is not on the IU Health formulary, and I could find no data on pricing. The fourth and final drug, which is not a neuraminidase inhibitor, this is an endonuclease inhibitor, and it inhibits viral polymerase acidic protein endonuclease, which is quite a mouthful. But it therefore, in doing that, inhibits viral replication. This is also taken as a single dose. It is oral, and it's approved for ages 12 and up. The dose is based on weight, with those greater than 80 kilos taking an 80 milligram dose, and those between 40 and 80 taking a 40 milligram dose. We don't have data for safety on pregnancy and lactation. The side effects are listed here. Diarrhea, about 2%. The clinical trials that led to FDA approval said that the majority of side effects were not reported more often than placebo. So it seems to be well tolerated, but there are post-marketing reports of serious skin rash, facial swelling, GI bleeding, anaphylaxis, and delirium. So we don't have much experience with this drug. I've never prescribed it. It is not on the IU Health formulary, and the approximate cost is about $180 to $200 for this single dose pack. There's an older class of drugs. For those of you, especially the directors, probably remember using Amantadine or Romantidine, or at least learning about them. These are no longer recommended. They only ever treated influenza A. Because of the pharmacology, they're not active against flu B. They have high rates of resistance. They're no longer recommended. So you can kind of wipe those out of your memory banks unless you're treating some other neurologic conditions. So we've mainly been focusing on treatment of influenza illness, but I wanted to say a few words about prophylaxis. Who do you prophylax and when? if it's, so basically when you're seeing patients who are close contacts of flu cases, if it's less than 48 hours since the time of exposure, if the patient was exposed during the infectious period of the individual, of the index case, and particularly if they're high risk, you want to consider prophylaxis of these people, of these individuals. It is thought that if patients have been fully vaccinated for flu, and that the vaccine is thought to be effective or a decent match, that you really don't need to prophylax. I will say that that last point is really hard to know, and oftentimes I don't feel like we have a good handle until after flu season whether the vaccine was a good match or not. And so that's a tough one. I think it kind of comes, I usually personally do a lot of just informed discussion about prophylaxis and you know, kind of discuss the merits. Do you want to start the drug now? Do you want to just kind of monitor for symptoms and then we'll jump on it right away? And I think it kind of comes down to personal preference and parental preference in a lot of cases. Medication prophylaxis, you can use either Tamiflu, or I should say Osultamovir, or Zenamovir. And the dosage is the same dose as the treatment dose, you just space it out twice as long. So in adults, instead of 75 milligrams twice daily for 5 days, you do 75 once daily for 10 days. And so it's the same dose. That makes it a little bit easy to remember. You just need to space it out, give it once daily, and give it over twice the amount of time. So same with children, you space the dose out over 10 days. Typically for the ages of 3 to 11 months, you would dose, again, 3 milligrams per kilo, kind of weight-based. The AAP and the CDC do not typically recommend prophylaxis in children under age of 3 months unless it's clinically critical, and they don't really elaborate on what that means. I think if you have a preemie baby that's already had pulmonary issues, such as bronchopulmonary dysplasia or something along those lines, and you feel like this is someone that's just super high risk, that would be a case where you might consider prophylaxis in a young infant. For your robust infants who are breastfeeding, particularly breastfeeding, getting some passive immunity, I think that it's probably not warranted. So now I want to talk about vaccination, arguably probably the most important part of this talk, as we try to really prevent influenza illness and death. And so most of the information that I'm sharing with you on updates for vaccination comes out of this publication. This is a yearly publication, and I recommend if you're a resident, once you graduate and you're out of the residency, you're out in practice, you want to really pay attention to this publication every year. Generally comes out toward the end of August, and it's going to give you a nice summary of updates for influenza vaccine season. So consistent with prior years, we recommend an annual vaccination of all individuals 6 months of age or older who do not have contraindications. We'll get into that in a second, what contraindications might be. They do not recommend preferentially one vaccine product over another. And that primarily is because to date, we just don't have any comparative efficacy data that is compelling to use one vaccine over another, other than the high dose, which I'll talk about in a moment. And then they do recommend making special efforts to vaccinate high-risk groups. So vaccine updates, Fluzone is now quadrivalent, which means it has 4 different flu antigens in it. And one of the things that changed last flu season is that children from 6 months to 35 months, they can either receive the so-called pediatric dose of 0.25 mLs or the adult dose of 0.5 mLs per dose. And again, that was a new change for last flu season. Prior to that, all children in that age range received the 0.25. And so this is an interesting recommendation because it you know, kind of goes either way. And so as a doc, you say, well, which is better? You know, I guess that there's not enough data really to say that one is for sure better than the other, but there's safety to give the 0.5 ml dose for children. I think this is particularly helpful should we run out of the 0.25 and we still have children that need immunization. We can give them the adult strength. Children and adults who are 3 years and up should always receive the 0.5 ml dose unless they qualify for the high dose. And let's talk about that on the next slide. So the high dose flu, sorry, didn't click, there we go. Fluzone high dose actually contains 4 times the amount of hemagglutinin per vaccine virus in each dose. So what do we mean by that? Each flu vaccine has 4 different virus antigens, and there's a certain amount of virus antigen for each of those 4 viruses. And in the pediatric 0.25 ml dose, it contains 7.5 micrograms per ml, right? Per dose. Sorry, 7.5 micrograms per dose. The regular adult dose contains 15 micrograms per dose, and the Fluzone high dose contains 60. So there is a pretty large variation in the amount of antigen that's present. A study of Fluzone high dose, this was actually done a couple years ago, and it involved the trivalent, which is the 3 antigens, indicated that the high dose vaccine was 24% more effective in preventing flu in adults 65 years and older. It was associated with a higher incidence of injection site soreness, redness, muscle aches, headache, and malaise. That was a little bit more common than as compared to the standard dose. So there are some children who require 2 doses of influenza vaccine in the course of a single flu season. And that takes place if the child is between the ages of 6 months and 8 years and has not had a prior flu vaccine or has not had at least 2 doses. Those 2 doses do not need to be in the same season. And so if a child comes in and they've never been vaccinated and they're between 6 months and 8 years, then you should give them 2 doses this season of influenza vaccine. If the child has had 1 prior flu vaccine, and it doesn't matter what the timing of it was, they should also receive 2 doses this flu season. However, if they've ever previously received 2 or more flu vaccine doses, then they only require 1 dose this flu season. For those children requiring 2 doses in a single season, they are to be at least 4 weeks apart. There are folks that you're going to run into that have a history of egg allergy. Egg allergy used to be considered a contraindication for flu vaccine. And that is because most available vaccines, including the Fluzone high dose and the Fluzone standard dose, are prepared by propagating the virus in embryonated eggs. And so there's a little bit of like crossover of the antigen. In a 2012 review, there were over 4,000 egg allergic patients who had received influenza vaccine, and there were no noted occurrences of anaphylaxis. However, in the Vaccine Adverse Event Reporting System, also known as VAERS, there have been rare but occasional cases of anaphylaxis. So what is a clinician to do? The ACIP recommends that for patients with a history of egg allergy, they may receive the influenza vaccine, and any licensed recommended age-appropriate vaccine product will do. They recommend that we observe them for 15 minutes after the vaccination and be prepared to follow emergency procedures and be prepared to treat an allergy should it occur. However, these are so rare that it is not an appropriate contraindication for flu vaccine. If the patient had a particularly severe reaction to eggs, such as airway closure and anaphylaxis, it is recommended preferentially to give the CC inactivated. CC is cell culture, so it's not cultured in embryonated eggs, it's cultured in human cells vaccine, or the recombinant influenza vaccine, which those 2 are the ones that are not propagated in eggs. Or the other alternative is to refer the patient to an allergist and have the flu vaccine administered there in the allergist office, just for an added layer of safety. Any patient who has had a prior severe reaction to flu vaccine, now this is different than reaction to egg. This is they've had a prior reaction to the flu vaccine. That is a contraindication, and one of the very few contraindications for the inactivated flu vaccine. The other possible contraindication is a history of Guillain-Barré within 6 weeks of receiving the flu vaccine. And so for those patients, they recommend avoiding future vaccine if they're not high risk for severe complications. However, for patients who are high risk for severe complications, they recommend a careful risk-benefit discussion and consideration for proceeding with flu vaccine. I mentioned in a couple of prior slides how pregnancy is a risk factor for severe flu. I've seen that twice in my career. 2 separate pregnant women who became very ill with influenza ended up with respiratory failure, ventilated, and in one case lost her baby. And this is just something that you don't forget when you see it, when you deal with it. And so I'm very careful with pregnant women in flu season, have a high index of suspicion and a low threshold for treatment and for testing. Flu vaccines have been given to pregnant women for decades with a good safety record, and influenza illness is definitely preventable. And the studies show that flu vaccine not only can protect pregnant women, but also the fetus, and once the baby's born, they will have some passive immunity. There was a study that came out in, I believe it came out, was presented in 2016 or 17. It was a observational study that occurred during the 2010 to 11 season and the 2011 to 12 season. And it noted an association between flu vaccine in the first trimester and risk for spontaneous abortion. And out of this study, they kind of isolated it to people who had had a prior vaccine containing H1N1 PDM09, which is a specific antigen, and then received a subsequent vaccine with the same antigen. They felt like that was really the subset of people who had this. However, in a larger study, that was not confirmed, and there was no increased risk for spontaneous abortion. So I bring this up because as we are clinicians who care for pregnant women, you may be asked whether there's a link, or they may say, well, I heard or I read that there's a link to abortion, to miscarriage, and I want you to feel confident to speak into that and say, well, there was one study a few years back that showed a small number of increased cases, but then a larger follow-up study did not confirm that. This is a nice infographic on the benefits of flu vaccine, and as we're kind of wrapping up the talk here, I just want to highlight, you're going to hear a lot of things and a lot of skepticism regarding a lot of vaccines, and in particular flu vaccine. I think flu vaccine has gotten a bit of a bad rap because it is known to be less effective. It's common to hear things on the radio or on TV that it's only 50% effective or 50-something%. And there's some truth to that, as with most things. There's a little bit of truth to that. However, on a population scale, the flu vaccine absolutely works. And every year, the CDC provides estimates of the number of influenza illnesses prevented by the vaccine, the number of medical visits prevented, the number of hospitalizations prevented. And you can see those stats here. This was representing the 2015-2016 flu season, which was not actually a particularly bad flu year, more like an average flu year. And they estimate 5 million illnesses prevented, 2.5 million medical visits, and 71,000 hospitalizations. In addition to that, for the same flu year, they estimate that the widespread vaccination prevented about 5,000 deaths over the course of that flu season. And some of those were pediatric, I'm sure. There was a bad flu year, 2017 to 18, and just with a particularly long duration of widespread flu activity. And because of that, the estimates for that year are even higher, about 7.1 million illnesses prevented, 3.7 million medical visits, over 109,000 hospitalizations and about 8,000 deaths prevented during that flu year. And that is despite the overall estimated vaccine effectiveness being 38% that particular year. They found that it was about 62% effective against influenza A, PDM09, about 22% effective against influenza A, H3N2. So that year the vaccine really missed for H3N2 at only 22% effective, and then 50% effective against influenza B viruses. So even with numbers like that are pretty low in terms of the percent effectiveness, we're still preventing a huge burden of influenza disease on a population basis. And I want to highlight that in this year of a COVID-19 pandemic, it's going to be very important to prevent respiratory illnesses, to reduce the conundrum that we're going to face diagnostically, to reduce the burden on the healthcare system in terms of ICU beds, in terms of healthcare providers, and in terms of PPE, and all of those things. We want to reduce the amount of flu in every way possible, and we definitely want to emphasize flu vaccine this year. That pretty much wraps up my presentation.